All right, the next session is our great debate session. We have two topics of discussion, friendly discussion. The first one will be moderated by Nick Kost. Nick Kost is an associate professor of surgery and urology at the University of Colorado and co-director of the surgical oncology program there. He's also the surgical chair or surgical vice chair for the Children's Oncology Group Renal Tumor Committee. My co-debater or co-speaker is Dr. Jan Gadzinski from Warsaw, Poland. He is a pediatric surgeon and surgical oncology expert. He is the Renal Tumor Study Group chair for the international group. So with that, we'll get started. How do I get this to work? There we go. I have no relevant financial disclosures. However, I do want to just state that I practice pediatric surgical oncology in the United States, and therefore I surgically remove renal tumors, so I may be a bit biased on that regard. I'm also a member of the Children's Oncology Group Renal Tumor Committee, and while I'm not acting as an official representative of COG, the views in this presentation largely reflect that of that organization. The objectives of this first debate or discussion are as follows. We hope by the end of the session everybody will be able to describe the preferred timing based on the clinical trial group of which you participate, explain the indications for delayed nephrectomy on COG tumor trials and the indications for upfront nephrectomy on SIOP renal tumor trials, to understand the differences in the complication risk following upfront versus delayed nephrectomy, and to understand the differences in staging and indications for adjuvant therapy between the two groups. Why is this topic important to discuss? Well, obviously the goal is to cure disease, but while minimizing morbidity, and we heard a really great discussion this morning with Dr. Weldon on the long-term effects of cancer survivors. So reducing or avoiding chemotherapy in a subset of patients is one of the upcoming goals of both groups, avoiding radiation therapy in a subset of patients, and ultimately risk stratifying so that patient selection for individualized or group-wise chemotherapy is optimized. And of course, doing all this while preventing relapse, which is much more challenging to treat and cure once that occurs. A recent report from the German group analyzed a large cohort of patients with relapse, finding risk factors for relapse included age greater than 48 months, larger tumor volume, and lack of lymph node sampling. And of course, we all know that histology plays a large role in relapse as well. And even for favorable histology Wilms tumor, relapsed cases are incredibly more challenging to treat and cure. So I'd like to start with, I have two case scenarios to walk us through some of those objectives that I listed. So the first one I just wanted to highlight is a 12-month-old with a history of IUGR, uncomplicated delivery and newborn course aside from that, who presented at 1 year of age with abdominal fullness. On exam, she was a healthy infant with a palpable abdominal mass. She was a little bit hypertensive. Her hemoglobin was 10. Other labs, including urine, VMA, and HVA, were normal. She initially underwent an ultrasound, which revealed a 9-centimeter mass, a chest CT, which did not show metastatic disease, and then underwent this CT of her abdomen and pelvis, revealing a decent size right-sided abdominal mass, measuring about 8 to 9 centimeters. So in this scenario, localized disease in a young child, the options are timing of nephrectomy, which brings us to our first discussion. She's 12 months old. So the COG approach would advocate towards an upfront nephrectomy. The SIOP approach would advocate toward neoadjuvant chemotherapy. And these primary surgical differences in approaches not only relate to the timing of surgery, but also the use of partial nephrectomy in non-syndromic unilateral diseases. So regarding the timing of surgery, the things that are agreed upon between the two groups are infants less than 6 months, as have been reported to have a higher percentage of benign disease, mesoblastic nephroma, and things that may not need chemotherapy. and the bilateral or unilateral high-risk syndromic patients, where both groups agree that a neoadjuvant chemotherapy and nephron-sparing surgery with preservation of renal parenchyma is feasible. SIOP uses a post-chemotherapy histology, which COG has also adapted. And both groups have also incorporated tumor weight, volume, the age of the patient, response to treatment. COG has also incorporated LOH molecular findings into risk stratification systems, and the evidence is here. These will be further studied prospectively in a risk stratification schema on AREN 2231, which should hopefully open soon. COG has demonstrated improved outcomes with augmented therapy for anaplastic Wilms, incomplete lung nodule response, and molecular characterization with LOH 1p16q. While SIOP has adjusted therapy based on histologic and volumetric response to neoadjuvant chemotherapy, thereby demonstrating improved outcomes with augmented therapy for high-risk blastema predominant Wilms tumor. And so the nuances of the approach can be illustrated by this evolution of prognostic factors, which is, I think, a really nice collaborative table from a collaborative report by Jeff Dome and the SIOP researchers in a recent publication, showing the evolution of what plays into how these patients are treated. So, initially with early National Wilms Tumor Study Group and SIOP studies looking at stage and tumor response to treatment, adding in histology, and then tumor weight, lung nodule response, and then more sophisticated analyses on, LOH 1p16q, lung nodule response, and then the histological response as determined by the SIOP post-therapy. Moving ahead to the current trial for relapse patient, as well as the proposed favorable histology trial, LOH, not only LOH 1p and 16q, but 11p15, 1q gain will be used to risk stratify. And the SIOP has incorporated lung nodule response as well as tumor volume. And so these are becoming quite sophisticated regardless of which cooperative group you are practicing under. So in this case scenario, this patient under COG underwent an upfront nephrectomy, was discharged home on postoperative day 2, and her pathology revealed a stage 1 favorable histology Wilms tumor. Nodes were negative, and she did not have any high-risk molecular markers, and so this patient avoided all subsequent adjuvant therapy and is followed as nephrectomy only. And so I think this case highlights one of the important nuances of the timing of therapy. Because of her age, she probably would have undergone a couple of rounds of chemotherapy under SIOP's guidance, but in this scenario, she was able to avoid chemotherapy. One of the other advantages is that the histology was essentially unmarred by neoadjuvant chemotherapy, and so we have had really good opportunity to evaluate the lymph nodes without potential loss of information, as well as the molecular factors. So let me just present another case scenario, which is slightly more challenging. A 2-year-old presented with left-sided abdominal pain and a palpable left-sided abdominal mass. He also was slightly anemic and had prolonged coagulation factors. He underwent initially an ultrasound showing a left-sided abdominal mass and followed by subsequent cross-sectional imaging revealing a large left-sided abdominal mass with pretty extensive nodal involvement. One would almost say image-defined risk factors. A couple more images. So in this scenario, his chest CT was without definitive metastatic disease, although he did have several 2 to 3 millimeter nonspecific nodule. And in this patient, the decision was made to undergo core biopsy with interventional radiology rather than upfront nephrectomy. And we can talk in a minute about why. His pathology revealed diffuse anaplastic Wilms. He underwent a port with testicular cryopreservation and was enrolled on 1921 and started neoadjuvant therapy per UH3 protocol. After 2 cycles, he had a really nice response, underwent nephrectomy with lymph node sampling. And final pathology revealed diffuse anaplastic Wilms with positive lymph nodes. He did receive both pulmonary and abdominal radiation. Given the high-risk histology and the uncertainty of the lung nodules, the decision to be more aggressive was made. However, his scans prior to the final cycle of UH3 on his initial therapy revealed 4 new pulmonary nodules, which were confirmed to be disease. He underwent ICE salvage therapy. Despite surgical resection, he passed away 15 months after his first pulmonary relapse. So this brings the question, was doing a biopsy up front the right thing to do? Was this largely driven by histology or surgical decision-making? And how can we do better? So just to highlight some of the indications, which probably most of you in this room know, indications for delayed nephrectomy under COG. In this scenario, this patient was in the last category, surgical judgment, due to the extent of the tumor. And the rationale for delayed nephrectomy, which Dr. Gudzinski will probably highlight more, is increased risk of surgical complications, although still relatively low, but increased risk of rupture with a larger size tumor. Usually right-sided tumors have a higher risk of rupture compared to left. Ken Gao in the COG reported this from AREN 3B2, looking at intraoperative spill rate based on size. And what they found was that at a size cutoff of approximately 12 centimeters, the risk of intraoperative spill was significantly higher, as well as the risk of spill with right-sided versus left-sided tumors. The odds ratio increased 1 centimeter for every 1 centimeter maximal diameter, and similarly with tumor weight. So we know that larger tumors do have a higher risk of intraoperative spill. Just to go through a couple of the other indications for delayed nephrectomy according to COG recommendations, the intravascular IVC extension to the level of the hepatic veins or higher is another indication for neoadjuvant chemotherapy, as outlined or as demonstrated here with extensive IVC thrombus. And this thrombus, as we all know, can extend even above the level of the diaphragm into the right atrium and even out the outflow tract. And both COG and SIOP agree that delayed nephrectomy in these situations is advantageous to minimize complications. Dr. Schamberger showed this initially in 2001, and then Luca Paio demonstrated this recently, as well as the PSORC with lead author Bindi Naikmathura. And in the Annals of Surgery paper from PSORC, this cartoon highlights the level of extension of the tumor thrombus and the distribution in the cohort. And I don't expect you to see all of this, but just to highlight those that underwent early surgery, which is that middle column, the complication rate was 55% compared to those who underwent neoadjuvant chemotherapy with regression or stabilization of the tumor, and response in the complication rate was only 25%. So it does make a difference in the surgical outcomes. And then I won't discuss the category that SIOP and COG agree on with the bilateral Wilms tumor. That's a whole nother conversation, or direct invasion of organs. But just we'll also highlight respiratory distress if a patient is not safe to undergo a surgical resection. So in the setting of delayed nephrectomy due to pulmonary metastases, it is still important to locally stage that patient to determine the extent of radiation. And a recent COG completed trial published by David Dix in 2019 demonstrated that in the setting of delayed nephrectomy, those who have rapid complete response of their pulmonary nodules can avoid pulmonary radiation, but would still need abdominal radiation. So it is vitally important to stage that for optimal outcomes. Those with slow incomplete response to their lung nodules will receive both abdominal and pulmonary radiation. and the rapid responders can avoid. And along those lines, lymph node sampling, as I alluded to, is extremely important in showing improved survival and outcomes. And those who undergo adequate lymph node sampling are demonstrated to have an improved survival. In addition, the likelihood of finding a positive lymph node increases as more lymph nodes are sampled. And so AREN 2231 will require a lymph node to be enrolled on the therapeutic trial moving forward. So Dr. Ehrlich and the renal tumor group looked at surgical protocol violations and found that failure to sample lymph nodes was the most common surgical protocol violation occurring at 65%. And the goal would be to sample at least 5 lymph nodes. We don't know the exact number, probably somewhere between 5 and 10. But importantly, to sample these within the drainage system of the kidney. And these have been established depending on the laterality of the tumor and the kidney being removed. So upfront versus delayed nephrectomy. Moving forward, there's going to be a sophisticated risk stratification for COG 2231, and delayed nephrectomy will be a sort of separate column or a separate arm of that study. Other factors that will play into the risk stratification will include patient age, stage, histology, molecular characterization, and response of pulmonary nodules. So this decision about when to remove the kidney is going to be vitally important in where to place the child on the risk stratification for 2231. And I want to thank Nick Kost for donating a slide or two. And just to kind of bring us back a little bit, the surgical contributions to the outcomes shouldn't be overstated. Because you can see when surgery started to play a small role in the management of Wilms tumor therapy relative to chemotherapy. The difference makers are adequate staging, so obtaining lymph nodes in the appropriate drainage system so that the appropriate medical and other local therapy, radiation therapy, can be administered. Preventing intraoperative spill, so doing a good operation, handling the fragile tumor carefully. The surgical timing and outcomes importance is very modest in the overall scheme of therapy. And excellent outcomes for most children, at least with favorable histology up front, can be achieved with both approaches. And as Dr. Godzinski will demonstrate here or show you in a few minutes, that the outcomes between the two approaches both have equivalent results. And so it's hard to prioritize one or the other, even though there are maybe some very strong opinions about the timing. So with that, I'll hand it over to my esteemed colleague.
First of all, thanks a lot for inviting me here. I came from Europe, from Poland, from beautiful old town, Wrocław, which is known of plenty of things, but also of having a lot of wars everywhere in the city. It is not so easy to get a permission, but my hospital got a permission for one, so if you come, we will show you with a proud. Disclosures are exactly the same, like those of Jenny, but marked with Cyoport ESG. I would like to start with the history. I'm quite a long time in this business, and I'm chairing panel of surgeons in ESG since 1993, quite a lot of time. So what was at the beginning? At the beginning, nephrectomy for renal tumors was associated with a great risk of rupture, bleeding, and other problems. Also, stage distribution was rather unfavorable. What to do with that issue? To improve technical skills of surgeons or material? Yes, of course, but maybe to find something general which will make surgery easier how to improve that, to use radiation therapy, chemotherapy, how long use it, pre-treatment. Sub-study number 1 checked in the randomized way whether preoperative radiation therapy may change stage distribution and very high at the time ruptures rate. And the answer was yes. The ruptures rate after preoperative radiation therapy decreased from 32% to 4%, and rate of stages 1 raised from 14% to 31%. But it was already very well known that radiation therapy in a preschool age is not a very good thing for kids, and the next study compared radiation therapy with chemotherapy. Practically the same we use up to now, and there were no difference in results. Still, the stage distribution was favorable, and still rupture rate was low. Of course, if 4 weeks improve situation, maybe 8 weeks improve even more. That was not the case. Randomized study between preoperative treatment lasting 4 weeks and 8 weeks show no further improvement in staging and no further improvement in rupture rate. So the golden standard has become 4-week preoperative chemotherapy in unilateral patients aged less than 7 months. And the nephrectomy. We do that probably the same way as you, but we have an easier situation in majority of cases. See how small is a tumor and how easy the surgery was, and the tumor bed is completely cleaned of adipose tissue. We do that always. And of course, at the end, we have to sample regional lymph nodes and not forget about it. Currently, pretreatment looks like you see. It is a little bit different for localized cases, for metastatic cases, and for stages 5. For stages 5, it needs some comments. It should not last longer than 12 weeks because longer pretreatment brings no further benefit. But if we see no response to this classical chemotherapy with vincristine actinomycin D, we can switch after 6 weeks to VP carbo, which is sometimes even more than effective. A postoperative treatment depends on plenty of things, on tumor volume, stage, and group of pathology. Different duration of treatment is for high risk and for low risk and for each of the stages. We'll talk about that later a little bit. So what is controversial, what is not? Absolutely not controversial is approach to huge extrarenal infiltrating tumors, treatment of kids under 7 months of age, majority of metastatic patients, bilateral patients, and IVC involvement, which we are approaching the same way, with the only exception which are thrombi, which are floating with the risk of pulmonary embolism and those blocking the blood flow back to the heart. But in both studies, these patients are approached primarily. And of course, syndromic patients. What is controversial? Standard unilateral patients age over 7 months, we give them preoperative chemotherapy. And we can do nephron-sparing surgery for unilateral cases in marked number of patients. There are different risks. Risk of complication, which is low and in favor of renal tumor study group, and the risk of misdiagnosis, which is of course in favor of COG. This risk of misdiagnosis is below 2% in RTSG, but exists. Staging, higher stages for COG, radiotherapy, lower rates of patients irradiated in RTSG, and partly my indication. In some cases, if we have unclear small peripheral renal mass, primary NSS is a good thing. Of course, if it is not small and if this NSS would be risky, we do TrueCut and regular treatment later on. How that transmits on the results? This is the study already cited by Jenny. It was a study done by British colleagues with randomization between immediate nephrectomy and delayed nephrectomy. And you see the rate of stages 1 after immediate nephrectomy, 54%, after delayed, 65%, and even more important, stage 3, 28% after immediate nephrectomy and only 9.8% after delayed nephrectomy. Yes, that's true, EFS and overall survival are not different. Complications. This is a historical comparison of 2 different studies, but anyway impressive. In the 90s, we had 8% of complications, and compared to the publication from NWTS3, in which this rate was 19%, made a lot of discussions. Study was redone by Mike Ritchie and myself, and times changed, and analysis was more homogeneous. Complications rates were in favor of RTSG, but the difference was not significant. However, tumor spill rates were still very much different with statistical importance. What is the prognosis for treated and not treated patients? Patients after upfront nephrectomy are getting more frequently radiation therapy, and nephron sparing surgery is rarely possible, but we need really fresh published data on that, especially on margins. Delayed nephrectomy, rare use of radiation therapy, and nephron sparing surgery in unilaterals, now widely explored in our study, has estimated upper limit of oncological feasibility with R0 resection at 10 to 15%. But in the high volume centers, there's a great difference between low volume centers in this issue and high volume centers. So, on NSS, we have few recent data published, especially on the margins. The factor of center and the factor of selection seems crucial. In Europe, we have a European Reference Network, which is a group of centers dedicated to more difficult surgeries, and we consider that this resection should be done only within this network. And what are the perspectives? I think that if we take into account the prognostic theoretical lifespan of the survivor, which is 70 years and not 10 like in adults, it is much better to live with both kidneys than with one. We have nice work done a couple of years ago by Jim Wilde on these partial nephrectomies in unilaterals. It was done on a group, very selected group of 97 cases, which consisted 4% of whole of the patients registered in the study. And you see that overall survival, event-free survival are the same in both groups, but there are failures also. And we should look carefully at the failures. Failures mean stage 3. There are 17.5% of stages 3, and the reason for staging 3 were either lymph nodes positive or margins positive. Margins positive, as you see, were found in 11.3%. How to predict the lymph node status prior to surgery, because those patients should be excluded of the NSS study. I was believing that it will be shrinkage of the tumor under chemotherapy or something like that, but it was not the truth. Initial volume less than 300 milliliters appeared to be a factor of lower risk. The shortest indication pictures for unilateral nephron sparing. Small tumor in a peripheral location and less than 300 milliliters. And this is a true case. It's a great pleasure to operate patients after chemotherapy with some really small tumors within 20 minutes. But not all are like that. In those more difficult, especially those which are bilateral, we have to use at first very good imaging before with reconstruction in 3D, and then try to operate them accordingly. Of course, this considers bilateral cases. Some polar and peripheral are easy ones. We resect them in veg without, of course, without any vascular exclusion. Larger polar tumors, my opinion is the best way is to operate them anatomically. That means to close the vessels going to the sector of the kidney involved with the tumor, and then practically bloodless resect this part. Vascular exclusion is not necessary. And the central tumors, some of them are not resectable at all. But if we see that there are vessel branches which are going to the healthy parenchyma, not in transit via tumor, may be resected either radially or according to York-Fuchs technique, longitudinally, of course, with vascular exclusion. And the time counts. Other arguments for benefit of the pretreatment. Chemotherapy makes a selection of the pathology variant into some different prognosis, producing regression of the tumoral tissue, differentiation, maturation, or resistance. And look at the two types of classification of histologies. After primary nephrectomy, of course, some are not Wilms tumor, as spezoblastic nephroma or rhabdoid tumor, and changed, modified with preoperative chemotherapy after pretreatment. Here you see in red those which are poorly responding to chemotherapy, but maybe of a good prognosis, like CPDM, or stromal predominant, which is usually very big tumor but not infiltrative, but also of very bad prognosis, like diffuse aneplasia. You have also a type which is called completely necrotic, with extremely good prognosis and completely killed tumoral tissue. How that corresponds to prognosis of different subtypes. Low risk group has 98 5-year survival, and the similar has intermediate group, but the aggressivity, toxicity of treatment is completely different. Low risk group is getting very little chemotherapy, and in stage 1, nothing, whereas intermediate risk is treated usually 27 weeks in majority of stages. And the high risk, we are not very happy. Still 74% 2-year survival, 76, 5 years survival. What does it mean? That means that if there is a first relapse, the prognosis is probably fatal, because overall survival is only slightly higher than event-free survival. So thank you very much for your attention, and welcome to Wrocław. We have one worse in the hospital. I'm working, and I will show you that. Some American colleagues already visited my place, and I think that those was fantastic visits. Thanks a lot.
Well, those are both really excellent presentations. Thank you. Does anyone have any questions? Okay. In the absence of that, maybe I'll ask one. You know, I think this is a great example of where the answer is, it's not always and it's not never for both sides. Do you envision any way that, you know, artificial intelligence or machine learning for imaging could give you the information ahead of time so you would know which approach was best for that individual patient?
Oh, thank you. I think that we have to use those facilities, especially augmented reality or artificial intelligence. I'm not very much sure about it, maybe for calculating the risk and the benefits in the future. The problem is even with robotic surgery, and very simple, because equipment for robots is at 10mm ports and very difficult to get small instruments. On the other hand, I do not believe very much in robotic surgery for pediatric oncology. Yes, future for augmented reality, for imaging, and for good preoperative workup.
And I think that question will lead us to a session later this afternoon on sort of virtual reality and some of the tricks and new technology. But I think, so I think that can play a large role into surgical planning. I think in the end of the day, you can use all those tools, but ultimately there is some judgment involved in that one piece, and I think that you have to use all the information you have to the best of your ability.
Yeah, we like to cross-promote things. So. Andy?
Thanks both for very nice presentations. Jan, if I understood you correctly, did you say that likely lymph node involvement is a contraindication to unilateral nephron-sparing surgery? And if so, why?
Very good question. Thank you. Theoretically, lymph node indication implies radiation therapy to the lymphatic chain, and lymphatic chain starts in the hilum. So at least a part of the kidney, let's say saved, will be irradiated on, and it depends on the doses. If you use 10 to 12 grays, maybe this kidney support that. If that will be, we use a little bit more for lymph nodes. If it's more, this kidney is at risk. Anyway, we are raising the risk of unilateral tumors operating on patients with the involved lymph nodes. But this is again only statistical. If we have low volume, it does not mean that there will be no lymph node involvement, but the risk is lower.
But you might use the opposite argument to say that you're going to get radiation anyway, and so that takes you off the hook if you have positive margins.
So yes, positive margins are really a problem, but I will tell you one example. We did everything correctly, small polar tumor. We operated on this child, polar resection, unilateral case, several lymph nodes biopsied. There were 9 lymph nodes in one. It was metastasis and the tumor was CCSK. The child got radiation therapy at the level of 30 grays and is now 5 years alive with functioning kidney.
Thanks for a great debate. A comment and a question. Comment is just one topic that didn't come up here, and if Max were here, he would maybe remind us, is that another advantage of upfront chemotherapy is the potential to do a minimally invasive nephrectomy. But then my question is, maybe we don't even need artificial intelligence. What if we get to the era where liquid biopsy, circulating tumor DNA can tell us that it's not rhabdoid tumor, it's not CCSK, it's not diffuse anaplasia, it doesn't have loss of heterozygosity. If we get to that day, is there any reason to do an upfront nephrectomy?
I was going to bring that up. I'm glad you brought that up. I think it will be an evolution. I mean, that whole table that I showed with the risk stratification evolution, I think certainly the circulating tumor cells are going to be there in the next phase study. But yeah, I potentially could see you get all the information, including the molecular characterization from a liquid tumor biopsy, circulating tumor cells, and treat and reduce the complications. You do lose the lymph node information. So I think that's the one piece you can't get.
But you get the post-treatment categorization.
Yeah, but you may lose some lymph node metastases information with pre-treatment.
Yeah.
So.
We are talking a lot today about the indocyanine green, and we use it during surgery just to visualize the lymphatics and the lymph nodes, believing that this will be a sentinel node first.
Hey, so this was great. I think, clearly the data have shown over the years that the outcomes are good the way SIOP does it, the outcomes are good the way COG does it, right? So that's why it's a great thing to discuss. We're all doing the right thing for these kids. But, there are differences, obviously, in distinct advantages that you both pointed out. And they're not necessarily in the same kids. So there's some advantages in one set of kids and some advantages in a different set of kids. So it sort of gets to Nick's point. It seems like there is probably somewhere in the middle. That young, very low risk kid that's got, likely a stage 1 tumor, you don't see any enlarged nose, they're less than 2, et cetera. You might spare that kid chemotherapy, right? So, and I think that was your first case scenario, Jenny, and that's So there's probably a lot to be said for that. Meanwhile, then you've got the very big tumor where we know the risk of rupture with upfront resection is 10-15% based on Ken's paper and some others. So you wonder, and perhaps in those kids, is it something to think about in terms of doing a delayed procedure? So the answer, like many things, is probably somewhere in the middle. But thankfully, we're getting excellent outcomes from both approaches. So anyway, just really a comment.
As we kind of wrap this part up, I think Tim's point's well taken, that 10 years from now, this conversation, I think, will be a lot different than it has been for the last 30 years. And I think then the challenge for myself and my role and Yan and his role is, will we learn from each other, right? We're going to both do things that could change this in the next trial. We're going to expand nephrectomy only up to kids age 4 if they have stage 1 disease. Will SIOP change their approach based on that? Would they think about doing upfront nephrectomy in some of those? And will we learn from the umbrella protocol about which kids maybe could be more eligible for minimally invasive surgery or for nephron sparing in the unilateral setting? So I think I say this to the group all the time, we're not the defender of the faith of upfront nephrectomy, but we need to be wise about when we deviate from that. And so we're going to have the opportunity to learn from each other because we're both doing studies. It's just hopefully our pediatric oncology colleagues will allow us to learn from each other.
Thank you. So I know we ran a little bit over, but you got an extra break before, so the next debate will run over the 2 o'clock time, which is okay. So I'd like to call up Erica Newman, Dr. Newman. She's going to be the moderator for this next session. Thank you. Dr. Newman is section head of the pediatric surgery at the University of Michigan and director of the Mott Solid Tumor Surgical Oncology Program. And so I'll let her introduce the next 2 debaters on the topic of degree of surgical resection for high-risk neuroblastoma.
Thank you. Hello, everyone. Welcome. This is really exciting. We have 2 international experts that will be debating a topic that most of us are still debating in the space of neuroblastoma. So I would like to introduce first Dr. Paul Losty. Dr. Losty? Dr. Losty has served as professor of pediatric surgery at Alder Hey Children's Hospital in Liverpool, which is one of the largest children's hospitals in the UK and Europe. Dr. Losty trained in general surgery and pediatric surgery in major teaching hospitals affiliated with the Royal College of Surgeons in Ireland, Massachusetts, Harvard, at the Mass General, and Alder Hey Hospital, Liverpool. He's worked as a university academic surgeon in Liverpool for almost 30 years. He delivers clinical and faculty leadership. He has major interests in surgical oncology, clinical, basic science research, education, teaching, mentorship, and has helped train generations of young pediatric surgeons in the clinic, in the operating room, and in the science laboratory. Professor Lofty is also the current president of the International Society of Pediatric Surgical Oncology. Dr. Lofty, welcome. I would also like to call up Dr. Andrew Davidoff. Dr. Davidoff is a full member and chairman of the Department of Surgery at St. Jude Children's Research Hospital in Memphis, Tennessee. He holds the St. Jude Endowed Chair in Surgical Research. He also has adjunct appointments in surgery, pediatrics, pathology, and laboratory medicine at the University of Tennessee School of Medicine. He joined St. Jude in 1997 after completing fellowship and training in general and thoracic pediatric surgery at the Children's Hospital of Philadelphia. His specific interests are in AAV-mediated gene therapy for cancer and monogenic disorders, particularly hemophilia, and anti-angiogenic cancer gene therapy. He is a past chair of the American Academy of Pediatric Surgery section. He's the current chair of the Children's Oncology Group's surgery discipline, and he's the president-elect of the International Pediatric Surgical Oncology Group. Gentlemen, welcome. Really excited for the afternoon.
It's a pleasure to be here. I've brushed up on my judo and karate lessons before this session, and I was saying to Bob Schamberger, I hope there will not be a Bruce Lee, Chuck Norris fight taking place. Both Andy Davidoff and myself are colleagues and indeed dear friends. we're both IPSO members, so my own views are not those of IPSO. They're my personal views, having been a surgical oncologist for well over 30 years. I was here 20 years ago, and I was saying to Bob just at a break, there's the abstract book that I dug out spring cleaning in my office a few days ago, and the resort still looks well. I have no conflict of interest to declare. I'm an Irishman, and we like to fight sometimes, but Andy's a colleague and friend, and I'm sorry to disappoint you. We'll not be seeing any punches thrown, karate kicks or round kicks. That's not going to happen. So I guess to start this story, well, you know, this is why we do surgery. We can't get enough of this. And I think the first thing I would say is that we all aim to do our best in the surgery of neuroblastoma. And we try to do what we can and make our patients better. I can't deliver this talk without acknowledging these two individuals. I don't know if Mike is here, but Mike LaGuaglia and Edward Calley, also an Irishman, have contributed an awful lot to the surgical journey and the story with neuroblastoma. So I pay my respects to these two individuals that certainly have inspired me to be interested in this tumor from my early days of residency working in Dublin. Here's another big name, and Bob Schamberg will recognize this gentleman, as will many of you in the audience. Robert Gross, who in 1953 said that this was the answer for neuroblastoma, extensive and radical surgery, which has a definite place and can lead to permanent cure. Of course, at that time, surgery was the answer for cancer, and a lot has happened since then with the development of chemotherapy, principally out of Boston with Sidney Farber, the father of chemotherapy, and of course the other modern-day therapies that we now have to treat these patients. However, I thought in the interest for the younger surgeons, to set the tone appropriate for this session, I need to give you a little bit of history. So here we are, Abson, 1993, Hilton Head, and here he is, the great man himself, a Cork man from Ireland, the surgical challenge of neuroblastoma, the overseas guest lecturer. And I was saying to Andy, these overseas guest lectures don't seem to happen at Abson anymore, but that's a conversation for the bar later as to why that has happened. Anyway, this is what Dr. Calley said at that time, and this is taken directly from his talk, the publication 1994. The results, that is his results, reported herein suggest that local control can be achieved in a substantial number of children who have advanced neuroblastoma disease. However, presently, that is all which can support the surgeon in facing this particular challenge. If you read the small print below that, combination chemotherapy may shrink advanced tumors in those with advanced stage 3 and 4 disease and ablative metastasis. However, subsequent complete surgical excision does not improve survival, that is overall survival. Approximately 2/3 of those with stage 3 disease and 1/3 of those with stage 4 will survive regardless of whether excision is complete. And at that time, Dr. Calley said the present results do not support the value of complete surgical excision. Later that same year, in Seminars of Surgical Oncology, Dr. Calley presented his technique for radical excision of abdominal neuroblastoma that you can see depicted in these cartoons. The technique pioneered and developed by Calley of subadventitial tumor resection. Some surgeons use this technique, others don't, and again, that's a subject for another talk, which we have presented at IPSO previously, most recently in Ottawa. However, this is Dr. Calley's conclusions again at that time. Radical operation for those with stage 3 and 4 locally advanced metastatic abdominal neuroblastoma is described. The surgeon's performance, tumor shrinkage is achieved by means of chemotherapy and metastasis, hopefully ablated. Given the difficulties inherent to performing this curative resection for disseminated neuroblastoma, the surgeon needs to be convinced that his or her efforts are indeed worthwhile. My results so far do not provide such a reassurance. I trained in Dublin with fantastic surgeon oncologist Ray Fitzgerald, who was a former president of IPSO. Some of you may know Ray, who's now in his late 70th years, continues to fly planes. And I looked at my own data, which we presented in Boston in 2010. Bob may remember that meeting. And these were my own outcomes when we looked some 10 years or so after I'd presented Ray Fitzgerald's results, which we published in the European Journal of Surgical Oncology in 1992 or thereabouts. And you can see, reading the slide, that what we found was a very small shift in survival for stage 4 disease, from about 12% to 22%. And our conclusion from that paper was, while complete tumor resection is clearly desirable, the findings from our own experience in Liverpool at that time suggested that the radicality of operation is not significantly associated with better overall survival and relapse, and the improved outcomes were more a reflection of the evolutions of newer treatments to treat this challenging and nasty disease. Let me take you forward again and leap forward to Tübingen in 2012, and Andy was there. And this is a meeting hosted by Professor Jörg Fuchs, again a great friend and colleague, fantastic surgeon, and a former president of IPSO. And I was lined up in a debate with Mike LaGuaglia, and it was quite interesting because in that audience was also Frank Berthold, who's a medical oncologist from Cologne. And Mike presented his results from Sloan Kettering, always impressive. And I had to follow Mike with my own debate on the subject. And I've never believed what I've read in the textbooks of surgery, and that's just a little take-home message for young residents. What you read today may be completely irrelevant tomorrow, and I've always questioned why we do things and continually searching for new answers or solutions to the problems we face as pediatric surgeons. So this is just a little primer, of the article I wrote in the Seminars of Pediatric Surgery in 2016. I'll move on. So for the first time in the world, we presented this paper at the Tübingen meeting 2012. I had to follow Mike, as I said. Frank Berthold sat in the front row with a huge grin on his face, as he seemed to like everything I was saying. It was too dangerous for the residents, Daniel Molisari, now consultant at Great Ormond Street, and Paul Farley, consultant at Manchester, to present this paper because it was so hot. And using tools of systematic reviews and meta-analysis, we set to the challenge to answer this question. Of course, with no surprise, our efforts at near complete tumor resection or gross tumor resection has an obvious survival benefit for our patients with high-risk neuroblastoma. However, the story was not so clear and conclusive for advanced stage 4 disease, where with the help of our statisticians, we could not prove a benefit to overall survival, but we did show an advantage to event-free survival. This paper, just for the young residents, had the most hostile response from several journals because of the message that we were saying. And this is what happens when you are discussing what is a controversial topic in surgery. We were not saying that surgeons shouldn't try their best, but we were actually looking and deep diving for the evidence. The paper went to The Lancet, and The Lancet editor rang me one Friday afternoon in Liverpool as I was about to leave my office. And he said, "Dr. Losty, I'm disappointed to tell you we cannot accept your paper for The Lancet. How are you aware of the work of Dr. Berthold?" And I said, "Tell me more." "Well, Dr. Losty, he's just published in the JCO this paper," and this was the paper. So Berthold sat in the front row, consuming everything that I'd said, raced back to Cologne, and they published this paper in the JCO. And this is the results of the study in JCO. You can read it. In the interest of time, I'll swiftly move through it. Combining the results of this study with those from the literature clearly shows that aggressive surgery has limited impact for high-risk neuroblastoma. Future trials are required to determine whether even less surgery, well, I tend not to agree with it because we're surgeons, we try to do our best, might be adequate with higher intensity multimodal treatments, and if indeed biological factors, which indeed we do all believe, may be correlated with the resectability of the primary tumor. This paper stole our thunder, and The Lancet couldn't take our paper because they like to publish the world's first. And I now know why Berthold was grinning away like a Cheshire cat in the front row, as I'd followed Mike LaGuaglia, which isn't an easy act to follow, basically telling Berthold everything he already knew. And following that, you can see the papers that suddenly the domino effect of our paper and that of Berthold's. Henry Rice's group published in PBC, showing no benefit to overall survival with gross tumor resection. Our colleagues in Babino Gesù, Alessandro Crockley is here, Alessandro Insero is the senior surgeon in Babino Gesù, also confirmed what we had shown with the data suggesting degree of resection didn't influence overall survival in metastatic neuroblastoma patients. And then our colleagues in Hong Kong, I was just there 2 weeks ago, followed us again, agreeing with what we had said in our initial systematic review meta-analysis. And that was then followed with the paper that I was asked to review, published by Daniel von Allmen, the COG A3973 study, which showed exactly what we had proposed almost 10 years before. And that is this paper, for those of you who are familiar with it or not, shows an event-free survival advantage, but not an overall survival advantage to greater than 95% gross tumor resection. This paper went back for a couple of reviews, and as I said, I'm happy to declare I was one of these reviewers. Now, you're getting the drift of my lecture. However, this paper then appeared from another friend and colleague of mine, Keith Holmes, and we all, quite a number of us in the field, are rather skeptical about this publication. Andy might have it in his slide pack, I don't know, but the criticism of this study that many of us have is nobody else has been able to show this. And when nobody else has been able to show something, you get a little suspicious. But the important point about this paper is that the surgical assessment of the resection was wholly subjective, and we really don't know what the surgeons did, and there's no post-operative imaging to know how much they did indeed removed or not. Anyway, I'll move on in the interest of time, but this is a paper that goes against everything I've just said, and as I said, many of us in the field still are skeptical about this, and I love Keith to bits, and we enjoy a beer together. Now, you might say, why would I be saying this? Well, I also trained in general surgery. I'm licensed in general surgery, and I spent a lot of my career doing breast cancer surgery, where I worked with a fantastic oncologist who made us all do modified rectal mastectomies and axillary clearance. Now, you will know that the surgical treatment of breast cancer has changed enormously, but high-risk neuroblastoma is a metastatic disease, and can you cure a metastatic disease with a local surgical operation? It's counterintuitive. It's not possible. And this led us on to try and address more carefully, I guess, in a greater analytical matter, what are we doing as surgeons? And when you look at subsequent papers that are published, or meta-analysis, some of which are not good ones, it's the big definition of what is meant by gross tumor resection versus complete. And you will know, as neuroblastoma surgeons, there's no such thing as a complete tumor resection neuroblastoma because of the very nature of the interval of disease. As Mike will tell you, Mike LaGuardia, they're all R1 resections mostly. In the interest of time, we'll move on. What we did is we've developed with COG and the German cooperative groups and SciPin a new surgical reporting form, and I'll just fly through this. You can just look at the slides as I fast track through them in the interest of time. But this is to be more, to if you like, get a more pragmatic and prospective approach to actually what we're documenting, and we've heard about standard operative notes, etc., mentioned earlier, about what we're actually doing when we undertake this surgery, and this is very important. So this paper was published in Annals of Surgery 2022. It's, as I said, you can see the authors there, and it's the way forward in terms of where we are with surgery and reporting when we undertake the surgery for neuroblastoma. As I close the talk, I would say the following. There have been no randomized trials led by surgeons, critically examining the effects of the extent of surgery in resecting high-risk neuroblastoma on scrutinizing event-free or overall survival. And I don't think we'll ever see those trials because ethically they'd be difficult to justify. What surgeon on the planet is going to not try and do their best resecting a neuroblastoma tumor? So it's going to be impossible to randomize patient A and patient B over, we're going to do half a resection versus a gross tumor resection. SciPin has taken this forward, and the HR-MBL2 study, we're now integrating post-operative imaging, taking it 6 weeks after surgery to actually compare the actual extent of surgical assessed resection with quantitative imaging, which will be used to help answer the surgical questions for the next generation as to where this debate continues to lie and guide treatment. Indeed, I believe the final outcome in high-risk neuroblastoma is determined more by metastatic relapse than by the degree of extent of surgical resection. I've said earlier, how can you cure what was a metastatic disease with a gross tumor resection operation? It's counterintuitive. And the great surgical debate will likely continue for some time. IPSA is a great organization. We have members in 85 countries and 365 cities. It's a nice group. The membership fee is very little. And we've got a bumper meeting lined up for you in Honolulu, Hawaii. So get out there on eBay and Amazon, buy your shirts and come and join us. I'm happy to take questions. And I said, Andy's a friend and a colleague. And if you thought you're going to see a Bruce Lee, Chuck Norris punch-up, I'm sorry to disappoint you.
I need the next slide. All right, I don't need to show a picture of myself. So thanks for the invitation, and I'm pleased to take the pro side of this argument. But before I start, Paul, I do want to say that I want to rescind the email that I sent you 2 days ago that said I'd be happy to write a chapter on neuroblastoma for your upcoming textbook, since you just told the entire audience that the textbooks are not of any value. Okay. So I will go through my slides quickly because I do want to get to the fisticuffs part of the lecture. So this is a now 20-year-old table from a paper that Michael Quaglia put together. And as you can see, on the far side are the number of publications that said there was a positive effect of primary site resection for metastatic neuroblastoma. On the near side are the much shorter list, including one by my esteemed opponent listed second. But you can see clearly that there's a statistically significant increased number of papers that favor the positive effect of primary tumor resection. So there you go, and I think I'll end there. No. Well, so the other thing is, it's probably a bad sign when both presenters, pro and con, use the same manuscripts as part of their argument, and unfortunately I'm about to do that right now. So this is the first paper that Paul showed from the German cooperative group, essentially showing no difference in event-free survival or overall survival regardless of the different degrees of resection, less than 50%, and so on. Then this is the second paper that he presented that I was privileged to participate in with Dan von Allmen, and that looked at the COG results for our high-risk neuroblastoma study. And it did show some benefit to extensive resection. And you can see in the far left is the cumulative incidence of local progression. So not surprisingly, a significant difference in that outcome, depending upon the degree of resection. And we used a cutoff based on about 95% resection. In the middle is the more modest, but still statistically significant difference in the event-free survival based on the degree of or percentage of tumor resected. And at the end is the not significant difference in terms of percent resection on overall survival. And then here is the last paper that Paul mentioned, led by, or first author was Keith Holmes on behalf of the SciPen group. And in this study, different from the other two, they showed improvements, significant improvement in all three parameters. So the cumulative incidence of local progression, overall survival, and event-free survival. But I do think it's fair to take a moment to really look at the curves, and the thing that, of course, is most striking is they're not hugely disparate in their trajectory, despite being statistically significant. So this comes from the power of large numbers in a clinical trial. And also to look at the actual percentage difference. So in the top curve, event-free survival, 33% versus 40%, overall survival, 37%, 45%. And so you can certainly argue about statistical significance versus clinical significance when looking at these data, but nevertheless, here they are. And this slide just sort of summarizes those three papers. One of the problems is that they look actually at different groups. So one looks at high-risk neuroblastoma, the others look at metastatic neuroblastoma. The other is the question of what is the cutoff for considering a gross total resection versus a complete resection versus a complete macroscopic resection. So there are certainly differences among the groups, but there are still some take-home points. The first is that about, maybe 2/3 to 3/4 of patients seem to be able to undergo a gross total resection. There is some suggestion from each of these papers, excluding the initial German one, that suggests that event-free survival and cumulative incidence of local progression can be positively affected. But one has to acknowledge that the effects on overall survival are modest at best. And this is in the background of the fact that there's a significant incidence of major complications, and these are just sort of noted and summarized here: hemorrhage, kidney loss, chylous ascites that persists, not to mention generic risks of anesthesia, prolonged ICU stay, and so on, and even a not insignificant mortality associated with this. But where I want to digress a little bit here and not actually talk so much about the surgery directly, but really throw in a new sort of idea in support of an aggressive surgical approach to these patients. And that has to do with the relatively recent advances in adjuvant therapies for neuroblastoma, the emerging concepts of targeted therapy and precision medicine, and the fact that it's pretty clear that most of these work better in the setting of minimal residual disease. And what better way to get a patient into a state of minimal residual disease than with surgery? And I just want to show two examples. So these were both published in the last year. This shows the impact of residual disease as judged by Curie score heading into a transplant on outcome. And so you can see in the far left panel that the event-free survival is improved for patients with a lower Curie score, therefore less tumor burden heading into transplant. And it's especially true in panel B for patients with MYC amplified tumors. So patients do better with their transplant in neuroblastoma. It's a tandem transplant in the setting of minimal residual disease. But really the study that I find most exciting, and if you only take one slide back with you from my side of this discussion, it's this one. And this was published last year in New England Journal of Medicine, and it looked at CAR T-cell immunotherapy targeting GD2, which we've heard this morning is widely expressed on neuroblastoma cells. So these patients had relapsed refractory high-risk neuroblastoma. The outcome for these patients historically has been really terrible, but now trying new innovative therapies, immunotherapy in this case, showed that both overall survival and event-free survival were significantly better in patients who went into the CAR T therapy with minimal residual disease. So again, suggesting that improving the patient's or lessening the patient's tumor burden heading into some of these newly arising adjuvant therapies really can be a benefit. And so to me, that sort of reinforces the idea of aggressive surgical approach being important. So to break that down in this concluding slide, direct and indirect benefits. So I reviewed the papers. We actually both reviewed the same papers, suggesting there was some benefit to the direct result of aggressive surgical approach. But I'd like everybody to start thinking about some of the indirect benefits of aggressive surgical approach, getting the patients into a setting of minimal residual disease so that the new and improved adjuvant therapies have a better chance. And I highlighted this point with a couple of recent examples. So thank you for your attention and happy to let the debate begin.
Thank you both. I can kick kick us off with a quick question for both Dr. Lasti and Dr. Davidoff. So what do you do in your practice?
You aim to do your best. That's what's important, because, you know, when we first presented this work, people thought we were trying to say, don't try and operate. We're not saying that at all. I'm on the journey of evidence-based surgery. It's a major part of my research focus, and you do your best. And clearly, as Andy has pointed out, you know, the surgery is not without its risks, and you need to know how to do the surgery very well. And Mr. Kelly and Mike McGuire have really been leaders in this area. But my discussion is more about the chasing the evidence for what we do. And I think, as Andy has pointed out, it's the newer therapies that may help us push the survival curves. The only paper that has suggested that this may be the case was this paper of Dr. Holmes. And as I said to you, many of us in the field are skeptical about that paper, you know. So I think there's a commonality in what we're both trying to say. And as I said, maybe Andy would like to make some comments.
No, I certainly agree with that last point. Erica, to answer your question very simply, we take an aggressive approach to all patients and try to, as Paul said, do our best, understanding the risks and benefits, but do uniformly take an aggressive approach.
Hello, everybody. This is Alessandro Crocoli from Rome, Italy. Thank you for your nice presentation. I have a comment for the presentation of Professor Lasti. About your last slide, you talked about the extent of surgery, and you cited the PSI-Open HR and BL2 protocol. One of the aims of this protocol is to compare the amount of radiotherapy that we administrate after the surgery, conventional versus the boost for the disease, for the residual disease. So probably if we improve the way we describe the amount of tumor we left or we removed, we don't need to do this kind of comparison. What do you think about it?
Indeed, and that's the point of this study, and indeed the point of the Annals of Surgery publication with the surgical report form. I would just encourage people to actually read the paper in Annals of Surgery from April, from Beijing, from Dr. Wang's group, which is intuitive and instructive, because the Chinese have been the first group since we first published that paper with the COG and Saipan group on the surgical report form, showing its utility and its usefulness. And China are now launching a multi-center study across the nation, looking at the surgical report form and where that would lead to in terms of taking us to the next chapters of the surgical debate story. But you're right, with the Saipan HR2 study, post-operative imaging has been agreed around 6 weeks, and with functional imaging, and obviously to know about what is the residual disease burden of the MRD, because as Dr. Davidoff has pointed out, these other therapies coming along the tracks, and indeed the functional imaging that the guys, the presenters gave earlier this morning will help us know exactly what we're doing. When you look back at what we've written as surgeons, we're sort of victims of our own success, because surgeons are not very good in their narrative reporting, saying what they did. And indeed, you can see this from what these functional studies have shown earlier today. And I think that is the way forward, the molecular imaging with the other advances in the biologics and neuroagents that may help us push this survival curve. But again, back to medical school days, when a cancer is metastatic, and I very much believe in the cancer stem cell story, these guys come back months and years later, and that's the challenge. We need effective metastatic ablative therapies that those cells will never come back. And then our surgery, the marriage will maybe show us a better picture.
And the second question is for Professor Davidoff, because the study you cited about CAR T-cell in neuroblastoma come from my institution, and we always struggle with our oncologists because the bulky disease they pointed out as burden is 5 centimeters. So I know that we are talking about refractory and relapsed neuroblastoma, but sometimes they asked us to do second and third look to reduce this amount of disease in order to undergo to this CAR T-cell. So I want to ask both you and the audience, What is your opinion to do this kind of surgery in this patient? Is something like a last chance for this patient. So how far do we have to push in order to obtain this goal?
Yeah, I think it's a great question. It's an important question, and one that I'm sure everybody in this room gets asked all the time. You know, setting of relapsed refractory high-risk neuroblastoma, survival is next to zero currently. Surgery doesn't have an intuitive role in that setting, but again, thanks to your colleagues and others, there may now be a role for getting to this state of minimal disease and allowing for the new adjuvant therapies to have a sort of a fighting chance, if you will.
Sorry? The problem is that you have to be something like brave to do a second and third surgery in a patient that you judged before unresectable, you know? And so it's like you are fighting by yourself, because if you don't operate, you are not brave. If you operate and you make some mess, you kill the patient in sometimes. So, you know, it's very struggling.
No doubt. My favorite saying is the courage of the non-combatant, and that's never more true than here.
Thank you.
And that's why the first surgery is important. So the message is, again, you know, Dr. Losty did not say don't operate. I'm saying do your best, because you have to do your best. And we all know the morbidity if you do it badly.
I just had one question. First of all, I just wanted to say this was a wonderful session, and I'm glad you didn't throw any punches. But I just had a thought, and just wanted to see what you both thought, actually, about this, which is years ago, Mike LaQuaglia showed that you really don't get much tumor shrinkage after the second cycle. And my biggest concern when we treat patients for a long period of time is that resistant clones develop within the tumor and also probably in other sites, but definitely within the tumor. And would there be some advantage to, I mean, we operate after the fourth or fifth cycle. In Japan, they operate after the end of induction. Would there be an advantage to attacking these tumors just after 2 cycles, even though it's a little bit bigger? We know the IDRFs don't change that much. What do you both think of that?
So I see Paul nodding his head, so I think we are going to agree on the answer to that. Actually, at St. Jude, we published a paper some years ago that suggested that patients who had an earlier resection of their primary tumor had a better outcome. Now, that was appropriately criticized for potential patient selection, and I get that. But we have adopted an approach at St. Jude where we operate as soon as the patient is deemed resectable. Now, that's a highly subjective, in my opinion, assessment, but I would say we operate more often after 2 cycles than we do after 4 or 5 cycles.
Jed, that's a very good question, and that's maybe where the surgeons can influence the next set of trials, because Dr. Schamberger knows he was one of the surgeons who taught us that it was so important to give these patients chemo to make the resection technically a little bit easier, particularly for the vascular and other organ injuries. But I think that's where we can, as surgeons, play a role. The more chemotherapy, you turn something soft into a stone. And you know, you need more than a chainsaw and a Kangle hammer and Barney Rubble and people like that to get those sort of tumors out. So I think that's where we need to be actively engaged as surgeons, because we follow what the oncologists tell us, you know. And as I tell our young residents, we're not puppies, we're surgeons. You don't always have to follow what they tell you. If I said jump over a cliff, would you follow me? So I think that's where we really need to get our feet around the table and maybe push the trials in those directions. The surgical trial could never happen for the obvious ethical reasons, but that's the sort of trial that we can have an influence with, Andy, yeah?
Thank you.
I'll make
make this quick. Doug Miniotti from Kaiser Permanente Roseville in California. Thanks again for this great discussion. I've heard you answer this question inferentially, but I'm just looking for a direct answer. I trained with Jed and attempt my best to do a subadventitial dissection. So when you say do my best and we are aggressive, is that what you're talking about? A subadventitial dissection to get as nearly a complete resection as possible?
So talking about...
And again, that's brave, right?
I was just going to say, speaking of bravery, so I know that Edward Kiley, that is his description of the operation as sub-adventitial dissection. I'm not brave enough to go into that plane. I'd rather leave a little bit on the outside of the aorta or whatever vessel dissecting. So I don't do that.
Doug, can I just come in there? I'm with Andy in this one. We presented in Ottawa, and your patients will get diarrhea, and it never gets better. So we've shown with the subadventitial technique of Dr. Kiley, and I get on my knees saying this as an Irishman to another one, when you do the operation that way, you risk vessel rupture and aneurysmal vessel changes, mid-aortic syndrome, and your patients, if they're upper celiac axis tumors, will get intractable diarrhea that will never go away. So as Dr. Davidoff said, I've never done the operation like that. I learned it from Ray Fitzgerald, and yeah. But do your best. We're both saying that we didn't do the Kiley technique. I think that's what we're saying, Andy, yeah?
Thank you for clarifying.
And those papers are published, by the way. European Journal of Surgical Oncology, JPS, you can read them.
Thank you very much. What an exciting session.